Do today. I want to cover pneumotrophic viruses. So we're doing well on time. We're doing pretty well on time, actually. So I'm not going to rush materials on. Just a few comments. We've had exam 3 on Monday. Most exams have been taken. We still have a few outstanding exams to be completed, mainly because people had issues with their maybe internet and things like that. So that's not completed yet. I gave a deadline for this Friday to complete all the requirements. So I'll know more about the exam on Monday, the stats and everything. But I want you to start thinking ahead. I know you don't want to think about exams this week because you just had one, right? Plus you have your practicums and maybe a quiz this week in the micro lab. But here's the thing, we're going to finish up virology probably by next Wednesday. All right, so next Wednesday, that's a week from now. And then I want to schedule another exam. I'd like to give you guys a week's notice. So what I'm thinking, probably 2 Mondays from now, not next Monday, but probably the following Monday, or maybe the following Wednesday. I'll let you know for sure on Monday when that exam would be. But the thing I want to say, this exam 4, it covers virology. So these are the PowerPoints I've already placed on Blackboard for you. It covers chapters 15, 16, and 17. All right? So that's what I want you to start thinking about. Also, I know you know this, time would just move so fast. Before you know this, we have finals. So your finals would as I mentioned to you before, would primarily be based on 2 chapters. So most of the information for the final will come from 2 chapters. That's mycology, the study of fungi and parasites. All right. Part of that exam is somewhat comprehensive. I haven't made that exam yet. But at some point, over the next 2 weeks, I'll give you more information on that. Nonetheless, things are getting pretty busy, right? It's already been, but it's going to get more busy as time moves on over the next 2-3 weeks, especially before your finals. So stay abreast of things. Be diligent. Ask your questions. Don't be afraid to bring things up or to email me to address your concerns, and I will. All right? So let me stop for a bit before I actually continue with this chapter. And maybe ask, are there any questions I can answer in the next few minutes before I start lecturing on pneumotrophic viruses? Yes, that's right. So this is so we talked about some basic things about viruses. If you recall their structure, well, their basic structure, their shapes, in other words, helical, icosahedral, and complex. We talked about their genomes. We talked about envelopes. We talked about viroids and then prion disease like mad cow disease and CJD and Kuru and fatal familial insomnia. Yeah, so we covered that already. So now we're actually getting to diseases, which is the bulk of the virus chapters. So we're going to get into that today. Other questions?
I have a question, Professor.
Yeah, go for it.
For the Introduction to Viruses PowerPoint, on the next exam, do we need to know the information on the tables for human oncoviruses?
No. So here's the thing. That's a very interesting question and an important one. So as we went through those tables, there's tons of information there, right? It lists the virus families, like herpes viridae. That's a family of viruses. Tells you about their genome, the size of the genome, whether or not they're enveloped or naked. That stuff I don't care about so much. Here's a reason why. When we do talk about those specific viruses, which would not be all of them on the table, by the way, I'm going to say, hey, this is the important thing about that virus. Here's an envelope. It contains maybe hemagglutinin or neuraminidase, as you see today. So those are the things I want you to focus on. Not so much nomenclature and all that categorization things, but the names of viruses and specific things about them. All right?
Okay, thank you.
Okay. Other questions?
When it comes to our grade, we also get to drop our lowest test score, correct?
That's right. So you have 4 midterms. You get to drop one of those. And then hopefully you've been doing well. You drop the lowest ones, maybe it's 80% or something like that. Yeah, you drop that one. You can't drop your final because it's weighted differently and it's comprehensive.
Okay, thank you.
And also, so I'm glad you brought that up because quizzes. I plan to have at least 8, the more the better, of course. So that brings me to this point. We're going to have a quiz on Friday at the end of this lecture. Somebody say, hey, but actually, what's that quiz going to be on? Once I see how far we get here, I'll let you know. All right, so Monday there'll be quiz. That'll be 6, actually, quiz 6. And then we have 3 more weeks left. Imagine if I gave 1 quiz a week, so that'd be 9, and then you can drop 3. So I'm targeting 8 minimum, and I promise 8 at least. We will have 8 one way or the other. All right?
So when is the quiz?
It's going to be on Monday.
Okay, thank you.
All right, good. And I'll let you know. If somebody reminds me, hey, Bideshi, what is that quiz on Monday? I'll let you know.
Dr.
Other questions
Bideshi,
yeah, go for it.
since this PowerPoint is pretty long, is this going to take more than 1 class period to do, or how is that going to pace out?
What do you mean?
Or maybe it's just on my end, but it looks like there's 136 slides.
Yeah, that's life, right? This is micro. So again, yeah, so we covered the first part. This is the introduction part of virology, and really they're very simple concepts like structures and all that stuff. So if you've been taking notes, I usually check things off as we go along. Here's what I can't cheat you from your education for sure. So there's a ton of things I want you to read, but again, think about the exams you've had so far. They're not tons of memorization. You have to memorize all the facts on the slide. As I go along, I say, hey guys, here's H1N1. What does that mean? Well, I say to you, in this case, para-influenza, what does croup mean? So those are the things I'm going to focus on. So somebody asked a question about the tables and naming things according to family names. I'm not, as I mentioned to you before, I'm not interested in things like that. All right. So just stay abreast. Keep little check marks. Hey, Bideshi said this is important. He's going to want me to know that stuff. And I'm going to focus primarily on diseases. So your quizzes are very general. Typically, virus structures. If you have a quiz next week, what's a capsid? What's a capsomer? Can DNA? Can viruses have both DNA and RNA? So what's a prion disease? What's a prion protein? So those concepts I do want you to know. Are we good?
Yes, thank you.
All right, cool. I know. You got to realize I have to condense all of this stuff into 70 questions. And I try to make it clinical because that's what you need to know. Basically, signs, remember signs, names of organisms, in this case, viruses, signs and symptoms of disease, maybe some peculiar things about them, like rashes, for example. Yeah, so those are the things I want you to focus on rather than memorize everything. All right, other questions? All right, guys, here's my objective today. We've already talked about some basic things about viruses. I want to focus on disease now, and again, this is the most important part of virology for us. So in this lecture, in this PowerPoint lecture, I have 2 different topics, all right? I'm going to focus on one of them today. So I'm not going to rush through the materials. I'm going to focus on pneumotrophic viruses. The other section in this PowerPoint is on dermatrophic viruses. So pneumotrophic, as you guys know, pneumo refers to the lungs. These are viruses that actually infect the respiratory passage, all right? So in other words, there's something that just appears on my tape. Approve. Okay, so that's the first time I saw that. So people, I guess they're chatting with me. That's cool. So yes, you have the clearance to, if you want to annotate or write on the slides as we go along, you can do that, no problem at all. All right, so we're going to discover some viruses, some really important ones that actually cause pneumotrophic infections. And yeah. So we're going to look at upper respiratory tract viruses and then lower respiratory tract viruses. The second part, of course, is on dermatrophic viruses. These are viruses that infect the skin. So if I say to you like chicken pox or measles, and then even herpes, those are viruses that cause infections that you can see on the skin. All right. So I'm going to talk about virology from this perspective, pneumotrophic viruses, upper respiratory tract viruses, and then lower respiratory tract viruses. There's not much to learn regarding upper respiratory tract viruses. I do want you to know some names of viruses that can cause infections in the upper respiratory tract. But nonetheless, before I get to that, I want you to commit this to memory here. Think about this. You guys will be nurses one day or in some area of the health field. And you know, there are certain things you should know right off the bat. For example, forget about the slide for a bit. If I said to you influenza, well, what time of the year does influenza occur? We kind of know that. It's wintertime, right? So maybe late fall or during the wintertime, that's when we see most cases of influenza infection. So this table goes like this. It tells you the most important viruses that cause respiratory disease, and it tells you the time of year. As you can see, for influenza, coronaviruses, and something called respiratory syncytial virus, generally we see this in late fall and then in the wintertime. All right? Kind of overlaps maybe with the spring, but not too much. Late fall and then wintertime. That's the big, most important thing I want you to know about this. Parainfluenza causes a mild type of influenza, hence the name parainfluenza. But we see this maybe in the fall, all right, and then in the springtime. Other ones, rhinoviruses. Rhino refers to the nasal passages. We see this primarily maybe in the summertime, just early fall, and then in the late spring. And then finally, we have enteroviruses we can see in the summer months. And then finally, we have something called adenoviral infections we see all through the year. All right, so some of them, we have specific times in the year where we see them or we expect to see them. Others, they can occur year-long, like adenovirus infections. Now, you notice I have coronavirus, right? We're going to find out when it comes to respiratory infections, yes, we're dealing with a COVID-19 situation right now. In 2002, we had SARS-1. Then in 2012, we had something called MERS. They're all bad coronaviruses. But realize this. Most coronaviruses cause upper respiratory tract disease. In fact, about 20% of all upper respiratory tract diseases are caused by coronaviruses, but it's not the coronavirus that you're thinking about, COVID-19 in particular, all right? Okay, so again, for upper respiratory tract diseases, this is what we've been looking at. Rhinoviruses, I just mentioned, coronavirus and adenoviruses. Those are the most common ones. They cause common cold. Now, the influenza and the common cold, that's two very different diseases, all right? For the lower respiratory tract diseases, what I'm going to focus on today is influenza. I'm going to spend a bit of time on influenza, talk about a virus called respiratory syncytial virus. I'm going to talk about even parainfluenza and then a few other viruses. All right, I'm going to talk about COVID-19, big time, because this is what we're going through right now. And a couple other coronaviruses, including the one that's called SARS-CoV, 2002, 2003, MERS-CoV, CoV stands for coronavirus, 2012. All right, let me just say a few words about upper respiratory tract viruses. Top of the list is rhinoviruses. So rhino, think about this. Rhinoviruses can cause inflammation or infection in the nasal passages. So rhinitis is something they can cause. So it's one of the primary causes of the common cold. So the common cold is very different from influenza, as I mentioned. Typically, there's no increase in temperature. Generally speaking, you might have a mild temperature to begin with, but generally speaking, you're not going to have a very high fever to begin compared to what we say influenza, unless there's some underlying conditions. It just depends on the patient, but in general, all right, we don't see high temperatures at all. Okay, so again, we have over 200 strains, many different strains of rhinoviruses. So this is one of the top causes of upper respiratory tract disease. The other is adenoviruses, many different strains also. And then, of course, coronaviruses can cause upper respiratory tract diseases. Let me just say this. With the rhinoviruses, you don't tend to see infections deeper in the lung. Here's the reason why. And I want you to remember this little fact. They grow best at 33 degrees centigrade. So this is like in the nasal passages, the airways there. It's not a pretty high temperature compared to the internal body, where the body temperature, it's about 37 degrees centigrade, all right? So the rhinoviruses, they kind of confined to the upper respiratory tract. They're limited because they can't replicate at higher temperature. Now, I have a little sentence here, and I always ask this in all my classes, actually, that I teach regarding infectious diseases and viruses. So this is something we used to say way back when I grew up in the 70s and the 80s. This was something that was quite common, and the 60s also. You can send a man or woman to the moon, but you blank, blank, blank. Maybe your parents know this, but you probably don't. Maybe I'm making an assumption here. Can somebody complete my sentence? You can send a man or a woman to the moon, but you... Any ideas? Well, let me complete it for you. You can't cure the common cold. Here's the reason why. We have so many different strains of these viruses. I mean, tons of them. It's very difficult to develop an effective vaccine. You have to cover all the strains. And not only that, many of these strains are what we call RNA viruses, and they mutate fairly readily, or pretty rapidly, I should say. All right. So again, with the common cold, primary top of the list are these two, and of course, coronaviruses are included, rhinoviruses and adenovirus. So most of us have had a common cold. Typical symptoms that you see: nasal congestion, maybe a runny nose, rhinitis, scratchy throat, and sneezing. But those are kind of obvious symptoms. I do want to point out this, though. Depending on the patient, especially kids with asthma. Now, think about this. Asthma can be very serious, right? Especially among little kids or young kids. So imagine they have asthma and now they have a respiratory disease. You see, that's a complication. So again, things can be more complicated than I just presented. In other words, maybe no temperature, maybe a mild temperature, but people who have underlying conditions like asthma or people who are immunocompromised, they can have some more serious complications like bronchitis. This is inflammation of the bronchi, which are the air passages, air infections caused by these organisms, pneumonia. This is where the organism goes deep into the lung, but not so much the rhinoviruses because they don't replicate at those temperatures effectively. People who have sinusitis, again, these are conditions that can be involved with this. So if you notice, we're going to see secondary bacterial infections a lot. When people have virus infections, they might recover. But during that recovery period, guess what? Because the immune system is suppressed, what can happen? We can now have infections with bacteria. And that can be even worse, especially in mold. All right? I want to move on next to lower respiratory tract diseases caused by viruses. And again, I have a nice little list for you, but just to give you an inroad into this, we have influenza, of course. You're going to find out there are 3 types of influenza virus. They're called A, B, and C. Respiratory syncytial virus, or RSV, all right? And then parainfluenza, we have RSV-like diseases, but then we have the coronaviruses. So the major ones would be SARS, MERS, and the current one is COVID-19. I'd like to remind you about 20% of all upper respiratory tract viral diseases, they're caused by coronaviruses, except it's not these dangerous strains. So it tells you what the agents are right here on this column, signs and symptoms. This is a pretty cool table to study. Transmission, again, we're looking at respiratory diseases, so primarily through respiratory droplets. And then, of course, treatment. I don't test you on that so much, but then, of course, to prevent prevention. So good hygiene practices, masks, for example, with coronaviruses. So there we go. On top of the list is influenza. There are 3 different types of influenza virus. They're called A, B, and C. I can summarize all of that stuff here in this table. So this is a pretty nice table I want you to know. Just a few things from the table. First of all, we have A, B, and C. The reservoirs, where do we find these viruses? So take a look at them. For influenza A, which is the most prolific, you find this in humans, pigs, and birds. So those are the 3 animals, including humans, that harbor this virus. For the B and C, you only find in humans. Right, so we don't tend to find B's and C's, and I guess you can find them, but they don't cause disease primarily in pigs and birds. Typically, it's humans. So again, epidemics, which one's involved in epidemic? A and B are involved with epidemics. C, we rarely find. So this is not involved with epidemics. Pandemics, that means worldwide. Which one of these viruses go worldwide? It's typically A. All right. So we already talked about a seasonal. I don't care that you can know all this stuff here. You can if you want to. I'm not going to limit your knowledge. But the reservoirs, A, humans, pigs, and birds. B and C, only humans. Epidemic, A and B are involved with epidemics. And then pandemics, typically is only A. All right. Now, a few other things. I don't ask you about stats too much, but keep in mind, every single year we have a new influenza virus. That's why there's a new vaccine. We're going to see why in a bit. Why do we need a new vaccine every year? Because the virus changes, and that's going to make sense to you in a few minutes, all right? But morbidity seen, how many people are actually infected or affected by this virus? The numbers, the percent actually depends on the season, all right? Anywhere from 5 to 20% of the US population gets the flu in a typical year. Now, think about what that means. The stats for the US population is like between 330 to 350 million people. But let's just go to 300. Let's just say there's 300 million people in the United States. Based on this stat, basically 15 million people to 60 million people, that'd be the 20% limit, actually gets influenza virus. You never know that, but that's a lot of people, right? Now, this requires about 200,000 hospitalization. Mortality, how many people actually die every year because of influenza? Again, depending on the season and depending on the infection rate, we have between 3,000. It might not seem like a whole lot unless you're in that category, of course, or you have members, families in that category, to about almost 50,000 people dying every single year. Now, just to compare to COVID-19, we're about 210,000 people. So you see way more people dying from a typical outbreak of influenza. All right? Okay, so 49,000, that's a lot of people. It costs a ton of money to actually take care of these problems, but that's not significant when it comes to people's health. All right, so let me move on. So how would you distinguish influenza from the common cold? One of the basic things I want you to remember, and don't forget it, with influenza, you tend to have a very high fever, and that appears pretty suddenly. So again, you're standing next to a person who has influenza, they're coughing up a storm, you breathe in some respiratory droplets, and then there's an incubation period. This is the period from the time when you're actually exposed to the times where you start showing some symptoms. This takes about 4 days or so. And then pretty soon in the 5th or 6th day, you have suddenly you have a high fever. So that's really important. You don't see this with the common cold. So I tell my other class earlier, I used to chuckle when students say, hey, I have a cold in the summertime. No, I have influenza, but it's summertime. You probably won't get that in the summertime. Most likely you would not. All right? So this high fever can persist for many days, sometimes a couple of weeks, depending on the individual. People can have runny nose, which is rhinitis, and then pharyngitis. This is inflammation of the pharynx. Hold on 1 second. Yes. Yes. All right. Yeah. And plus, if you want another week, you can have that too.
Okay, so you want to keep it so.
Yeah, exactly. All right. No problem. All right, guys. Sorry about that. I just had to answer the question for TAs. Okay, so again, that's the common thing that you see. Here's a nice expansive list of signs and symptoms. But again, some of these things are very general, like fever, but a high fever during flu season, that's something you're thinking about. Maybe that person has influenza. All right, I want you to understand what can happen with a disease like this. People have influenza and they might recover. Most people recover. But other people can have some major complications depending on their immune state. For example, individuals can have tracheobronchitis, so the trachea and the bronchi, they're inflamed, or just bronchiolitis, where the bronchi are inflamed. This is a terrible problem. Think about older people, or any patient with COPD. This is obstructive pulmonary disease, congestive obstructive pulmonary disease. Oh gosh, how can I forget that? All right. So they can have some major problems. Of course, pneumonia. And then I'm going to point this out again. So the important thing, secondary bacterial infection. So here's the thing, somebody has influenza, and now they have an extensive state of that disease. Well, it's not influenza anymore. What happened? Because the immune system was suppressed, then you have bacteria now causing infection in the lung, which can even be more serious, all right? Okay, so let's take a look at the types of infections that you have. Generally speaking, when bacteria are involved, this is a secondary infection now. Staph aureus can cause a miserable problem. So these individuals can pick up Staph aureus in the hospital, so it can become a nosocomial disease. So picture this, somebody has influenza, they end up in the hospital, and then they stay for longer than expected. Why? It's because now I have bacteria causing disease in the lung. So Staph aureus is top of the list, followed by organisms like Streptococcus pneumoniae, especially in older people, and then Haemophilus influenza in younger people. So myalgia, this is muscle ache, inflammation of the muscle, myositis, and myoglobinuria. So again, these are terrible conditions to have. Now, I want you to put a mark on this one. So things I want you to, I'm going to lay it out for you. Secondary infections typically caused by bacteria, all right? Now, there's a disease called Rye syndrome right over here. We don't really understand why it occurs, but here's a link. When people have viral diseases and some other diseases, and you give a person aspirin, especially in younger people, primarily in younger people, what happens after this occurs, people can end up with encephalopathy. This is abnormal. This is a problem in the brain, all right? And then we have fatty liver degeneration. So these are the common things that you see with Rye syndrome. Again, we don't really understand why it occurs, but it's linked to aspirin use. Here's what the problem is. If kids have this and they end up in the hospital, it's always so bad, it's so severe that they end up in the hospital. It doesn't look too good for them, all right? So 1 in 2 people can die because of this condition. So again, Rye syndrome, it can be a terrible, it is a terrible disease. It's linked to aspirin use and viral infections. What you see is encephalopathy, abnormalities in the brain, and fatty liver degeneration. Other complications that occur, but these are also very rare, encephalitis. This is inflammation of the brain that can occur with influenza. But also there's a disease called Guillain-Barré syndrome. In this case, what happens, their immune system can start destroying peripheral nerves. So these are all things that are linked. And by the way, these conditions are linked to other Rye syndrome and then Guillain-Barré syndrome, and viral encephalitis can be linked to other viruses also. Right? We can actually diagnose this pretty easily. There are certain tests we can use to diagnose this, but you don't have to know these types of testing. But I do want to spend a little more time on this, what the virus looks like, and then use the structure of the virus to help explain why do we see different viruses, or why do we need a new vaccine every year? Why can't we just have one vaccine that would take care of this forever? We can't, and you're going to understand why in a second. But you probably heard the term H1N1. What does that mean? You probably heard about pandemics of influenza, really bad ones. And then you hear about, of course, influenza occurring every year. What do those things mean? Well, to understand what this means, we have to understand the structure of the virus. So this is what the virus looks like. Influenza virus, doesn't matter if it's A, B, or C. What we see here, this is the genome, this is the capsids here. But if you notice, we're going to have 8 different segments. So the genome of the virus is actually is composed of 8 different segments. And this is an envelope virus. Take a look at it. Here's an envelope. And then we see these protein spikes on there. There are 2 major spikes. One is called the N spike, so hence N1H1. The other is called the H spike. These are just protein molecules that have certain functions during the life cycle of the virus. So the M spike, let's go to this one. Well, let's go to the H spike first. The H spike, it allows the virus to attach to those cells in the respiratory passages. The virus has to gain entry to the cell for it to replicate, right? So again, that H spike is called hemagglutinin. It allows the virus to attach to receptors on the cell. There are about 18 different types of this H spike. Now, the other one is called the N spike. That stands for neuraminidase. So here's a virus that's replicating inside a cell. It wants to leave the cell or exit the cell. It requires this protein, that N spike. So both of those are required for infection and leaving the cell. All right? Now, imagine I have 11 N types and 18 H types. I can have many different combinations of those depending on mutations. And that's what creates novel viruses every year. So again, every year there's a new vaccine, same virus. Why do we need a new vaccine? Because mutations occur in genes that cause these things to look a little differently. So in other words, the immune system have to literally recognize them all over again. But primarily the H protein and the N protein. There are many different variations of these. Think about all the combinations. You can have tons of different variations and tons of different strains of influenza virus. Now, this other slide points to something that's really important. Every so often, we have major pandemics. Again, you probably know this. If you go back to 1918, we had something called the Spanish flu. In 1957, we had the Asian flu. In 1968, we had the Hong Kong flu. And more recently, we had the swine flu, if you remember that. So again, I know most of you are pretty young. Most of you are probably between 18 to 19 or 20 years old. And this occurred back in 2009. So basically about 11 years old when this occurred. Okay, so this is called the Mexican flu or the swine flu or H1N1. We just talked about the H and N proteins. So again, they can change over time. The question is this: why do we have different strains every year, and then occasionally we have these major pandemics? So to understand that, we have to understand something called antigenic drift and antigenic shift. All right. So antigenic drift is simply this. Mutations occur as the virus replicates, but it's normal, it's routine, it's random, all right? Now, every year, because we have a new strain of the virus, it's primarily because of antigenic drift. Don't forget that, just random mutations. But when we have the big episodes, these big pandemics, and these are really nasty, Think about how many people can die. So the worst one we had so far was 1918. We don't have exact numbers on it, but it's estimated that about 100 million people died, 50 to 100 million people died because of this pandemic caused by this very specific strain of influenza virus. In the United States, that number is about 20 million. So this was the worst epidemic, or the pandemic actually worldwide that we know of. Whether or not this would occur again depends. I mean, last time we had the swine flu, not too many people died in comparison. That number actually in the United States is up to about 60,000 people dying. So this is during that time, 2009. And then with the Hong Kong flu, about 1 million people died worldwide. And then with the Asian flu back in 1957, about between 1 to 2 million people died. So these can be very dangerous. The question is, why do we see these episodes occurring? You know, every year, you go back to 1900, this is about 120 years ago. But really, there's been four episodes where we had these major issues occurring, where we saw a very different virus. This is a result of something called genetic shift. All right, so the changes that we see every year is a result of genetic drift. But what we're looking at are the terrible cases. That's a result of genetic shift. So let's try to understand what this is about. So imagine, let's go back to 1918, where we had the worst case scenario, where we had about 50 to 100 million people dying because of that pandemic. What actually happened? Well, first of all, let's take a look at the types of animals that are infected by influenza virus. This is influenza A. So chickens or birds can be infected, swine or pigs can be infected, and of course we have humans. So all these viruses, by the way, can replicate in each of these animals. So A can replicate in birds, it can replicate in swine, it can replicate in humans. Now imagine this happen, all right? Now follow me for a bit. What if I get two different viruses? Here, the swine flu and then the bird flu in one animal. It could be humans, it could be pigs, it could be chickens, whatever it is. But now I have two different viruses, avian or the swine flu, or avian or humans, or swine and humans, infecting the same host. Here's what's going to happen. Now follow this for a second, all right? In this case, I have the avian flu. So this is the virus that infects birds. Notice this genome here, those segments, those 8 segments are indicated here in blue. Now imagine this is the human flu. All right, let's just say this is the human influenza virus. And this genome here is indicated in red. But imagine this, I have an animal, it could be a human, it could be a bird, it could be swine. I have both of these viruses infecting the same animal. Do you see what can happen? Take a look at these. These segments can reassort. So I don't have all blues or all reds. In fact, in this case, I have 3 blues from avian, and from the human, I have 5 segments. Do you see what we just did? We just created a total novel virus. The human population hasn't seen this before, so there's no immunity to it. So again, when these viruses pop up every so often, it's because of reassortment. That's a result of that actually results in genetic shift. So the bad influenza strains are created by shift rather than drift. So let me summarize what I've just said to you. Every year we see a new virus. Why? Because mutations occur randomly. That's a result of genetic drift, random mutations. Every so often, and for the past 100 years, we've seen 4 major episodes. We see these pandemics occurring. That's a major change. That doesn't result with routine genetic drift. It's a result of genetic shift. This is where those segments I just mentioned, they reassort. So you don't have a virus that's purely human flu virus or avian or bird flu. You have a combination of those. They're very novel. The human population hasn't seen that before, and they can wreak misery in populations, all right? And again, the worst case scenario, or the worst case we had with the pandemics was back 100 years ago, 102 years ago to be precise, 1918, all right?
I have a question before.
Yeah, go for it.
That's okay.
No, go for it.
You said that like influenza A, because there's A, B, and C, and A is only found in like animals, and then B and C are found in humans. So like, how do the two different viruses come together if like one is only found in animals and one is only found in humans?
That's a very, very good question. So again, just by chance, imagine, let me give you a case. That's a very good question, by the way. Imagine I'm a human, right? Of course I'm human, and I have influenza. This is the human type. And imagine I'm a farmer, all right? And I have these animals. Here's my farm, I have pigs and chickens. And just by chance, and this happened just by chance, the swine got the flu. So now it has the swine flu, all right? Here's a chicken. Let's just see this chicken is not infected. But here's what happens. I transmit this to the swine. Now, in that animal, I have the swine flu, and I now have the human flu. So I have both of these replicating, right? And then this can occur. So their segments actually reassort. So this is what I have in this animal. And of course, I'm working with this animal that can now be transmitted to me. So I've just created, this system created a very different virus from what I started with. And now I have a major problem. Or this can occur between chickens. So here's the bird flu and here's the swine flu. Just by chance, this virus got into the pig, the chicken, the avian flu, and I have the same problem occurring. I have reassortments of these genomes. So these things happen. Again, they don't happen every day. Think about 100 years. We only have 4 times when we can say this really happened big time to cause some major problems. Are we good?
Yeah, so because it like mutates, that's why humans can contract it as well. Not mutates, but because it's like they rearrange.
That's
That's
right.
why.
Yes, the correct term would
Okay.
be reassort. If this mutations would be antigenic drift, right? So that's what we
Right.
see every year. Does that make sense?
Yes, thank you.
All right, cool. Other questions on influenza? All right, so hopefully you understand, like if I say to you H1N1, you understand what that means. It goes to the proteins that you find on the surface on the membranes back here. So here's my H protein and here's my H. We can have various combinations of those. All right, so the other viruses, I'm just going to do a quick survey. I'm going to tell you what I want you to know, and then I'm going to get to COVID-19 or SARS or just coronaviruses in general. I'm going to spend a little more time there, all right? So next on the list is viruses that belong to this family. And remember, I don't want you to memorize these names. I want you to know the name of the virus I'm talking about, but not the family names. So these are acquired in the community. They're called CAPs, community-acquired viruses. And one of them is actually parainfluenza virus. So this family of virus is just a nomenclature. It's just a classification system that we have. It includes 2 major ones, RSV, respiratory syncytial virus, and then the parainfluenza virus. All right, so we have parainfluenza virus. It also includes measles and mumps, but we're not going to be talking about mumps and measles yet. We're only looking at respiratory viruses. So RSV, respiratory syncytial virus, and parainfluenza virus. Those are the 2 I'm going to address here. And I don't have a whole lot to say about them, except for a few things, of course. So the human parainfluenza virus, there are 4 types, all right? But here's what I want you to know. They can cause respiratory infections, either in the upper respiratory tract, but also the lower respiratory tract principally. But here's the thing. Unless you have underlying conditions or you're immunocompromised or something like this, it's a mild disease in comparison to influenza. So you see some symptoms that you see that's kind of related. Maybe a cold, a cough, maybe not a cold, maybe high temperature, maybe a fever. All right, but there's not a significance that we would see for influenza. Now, here's one thing I want you to link. So I'm just telling you a few things I want you to know. This is a major cause of croup. You've probably heard that term before. Sometimes you hear people and they're coughing, but it sounds like a dog's bark. That's called croup. All right, so if there's one thing I want you to know about parainfluenza, it's one of the major causes of croup. Here's what happens. This virus can infect cells on the larynx. That's a voice box. So think about it. Now it relates to coughing, right? And again, it's inflamed. And when they cough, it sounds like a barking cough. So again, croup, parainfluenza virus. Now, next on the list is respiratory syncytial virus. This is an RSV. All right. So what do I want you to know about respiratory syncytial virus? First of all, it's a respiratory virus. Let me define the term for you as syncytium. So it's a syncytial virus. All that means is this: when cells are infected with the virus, they tend to aggregate. So they come together. That's called a syncytium. Hence, that's the terminology, respiratory syncytial virus. But what do I want you to know about this other than this? Primarily infects young kids, typically neonates or kids under 2. Most people have probably been infected with this virus and they're immune to it. But newborns in particular, it takes about 6 months before your immune system starts developing. So again, when we see major problems associated with RSV, it's primarily in young people, typically under age 2, and typically in neonates. I used to work in a hospital. I wasn't a clinician, but I worked in the laboratory with these types of pathogens. And I remember I stopped working there for about 10 years ago, but I spent about 25 years working in the hospital. I remember wintertime was pretty bad in neonatal wards. It's changed a lot. We don't see this occurring too much anymore. But when one baby has RSV, they got it from a nurse or some family member that's visiting them or whatever. When one person at neonatal ward had RSV, basically everybody in that ward had RSV, so they have to isolate the whole ward. The point is this virus tends to have a propensity for younger kids. Why? Because the immune system hasn't been developed yet. All right, globally, there's about 34 million people who get RSV every year and about 200,000 fatalities. We're not that high in the United States. All right, so we have very low numbers of deaths related to RSV. So things I want you to know: respiratory syncytial virus, infected cells form a syncytium. A syncytium, that's a collection of cells. They look like these multi-nucleated cells, but this is a syncytium, hence the name. Also, the target for this virus is neonates or kids under 2 years old. Doesn't mean to say older people can't get it, but they're less likely so because they've been exposed to it prior and maybe they have immunity to it. All right? So again, just to bring home the point, right here, kids under 2, very susceptible to RSV. All right, so I'm going to spend a little more time on coronaviruses. Just to have you realize that many coronaviruses are out there. Most of them cause very mild disease. It's not like what you're hearing about COVID-19. In fact, as I mentioned to you earlier, about 20% of all common colds, they're caused by coronaviruses. There are 7 different groups of coronavirus. The first 4, they cause, let me just say, mild infection. The other 3, of course, cause some major problems. And of course, the worst is coronavirus that causes COVID-19. All right, so let me just say a few about each of these, and then I'll get into specific things about them. So SARS stands for Severe Acute Respiratory Syndrome. COV stands for coronavirus. All right? So that came in 2002. We saw this in 2002, and basically this ended, that whole episode ended in about 2003. MERS stands for Middle East Respiratory Syndrome virus. It's also a coronavirus. This came on the scene in 2012. And again, we had a few cases all the way up to about 2019 or so, but very, very few cases. And then, of course, what we had starting in January, at least in this country, was SARS-CoV-2. So this is the one that causes COVID-19. That's a disease. So to be clear, SARS-CoV-2, that's the virus. That's the name of the virus. COVID-19 is the name of the disease. All right? Okay, so in fact, it stands for coronavirus disease 2019. That's what that means. Now, the reservoirs for coronavirus are animals. In this case, the most likely reservoir for all of these are bats. So then bats can actually feed on animals, right? So for coronavirus CoV, SARS-CoV, this is the 2002 one. Basically, that was transmitted from bats to cats, and then from cats to humans. All right? MERS came on the scene in 2012. And again, bats are the reservoir, but this coronavirus was transmitted to camels. And then, of course, from camels to humans. Very few cases, by the way. And then, of course, we have this one here. This is the most current one that causes COVID-19. So again, the reservoir was bats. And then bats transmitted it to pangolins. And so this is the prime one on the list, pangolins. I never knew what that was till this pandemic. And then, of course, snakes. And again, from here, it went to humans. Now, this virus apparently was transmitted in Wuhan, China. By the way, the first one in 2002 was also from China. And again, this is linked to wet markets. You probably know what that means. Basically, people are serving fresh wild meat. And by some means, somebody got infected with the animal virus, jumped into the human, and that human transmitted to other humans. And then it went pandemic. All right, so we had a global infection with coronavirus, SARS-CoV-2. This causes COVID. Now, a few things I want you to know. Now, there's a lot of slides back here. And again, some of these slides are for advanced classes. A few things I want you to know. Here's a coronavirus. This is an electron micrograph of the coronavirus. You see all these spikes back here. It looks like the corona of the sun. All right. But these spikes, let me blow it up. These are protein molecules. And these spikes, they bind to very specific receptors on your cells, or human cells, or animals. And then, of course, it enters the cells to cause infection and then disease. So this slide seems complicated, but here's all I want you to know. All right. And let's look at the viruses. SARS, SARS-CoV, this is the 2002 virus, and then SARS-CoV-2, this is the 2019 virus. The receptor, here's the virus, here's the spike. How does that virus infect cells? The primary receptor is this, is the ACE2 receptor. I want you to know that little fact, all right? That stands for angiotensin converting enzyme 2. That's a receptor that's present on many cells in the respiratory passage, and by the way, even in the intestinal tract and other sites also. You guys probably have heard this. Young people are more resistant to COVID-19, to getting COVID-19. Here's the reason why. One of the major reasons is because they have less receptors on their cells, ACE2. So as you get older, you tend to place more of these receptors, ACE2, on cells. So all I want you to know from this slide is none of this stuff here. I just want you to know that receptor is called ACE2. You're not going to find this in your textbook because that textbook was written before 2019. Next year, if they revise this textbook, for sure you're going to see COVID-19, right? Okay, so the receptors for SARS-CoV and SARS-CoV-2 is the ACE2 receptor on cells. For MERS, this is Middle East Respiratory Syncytial Virus. That receptor is called DPP4, dipeptidyl peptidase 4. By the way, these are similar receptors, all right? So again, you don't have to worry about all this stuff. I don't care about that. Okay, so let me just say a few things about the two we had previously, and then I'm going to spend a little more time on COVID-19. So if you go back to 2002, of course, we had SARS-CoV-1. And again, this originated in China. So from China, it went worldwide, but still, there was not a whole lot of cases compared to what we see. So I have the whole history here. And again, I'm not asking you to memorize facts, all right? So here's SARS. Again, it started in 2002. China, in Guangdong, China, actually. And then everything ended big time in 2003. So after this, we saw very few cases. When everything was done, this is the total number of cases that we had, all right? We had 8,000, just about 8,000 cases. And the death rate was pretty high. That's 774 deaths. Now, we're not looking at millions here, but here's what we're looking at, the death rate. That was pretty high. That's close to 10%, 1 in 10 persons, 1 in 8 to 10 persons, they die because of this. So again, it started back in China, in Guangdong, China, and then people travel, of course, just like we saw with COVID-19. People travel, and other people got infected. So we saw cases in France and all these countries that's indicated back here, but you see the Far East is where we had most of the cases. And then it disappeared. We haven't seen SARS-CoV for the longest time, all right? Again, individuals have typical symptoms. I don't want to repeat them again. That's related to respiratory syndromes. All right, everything kind of cooled down for a bit, and then came along 2012. So this is 10 years later, right? So another virus pops up. It's a coronavirus. Take a look at it, just like the same type of pictures. This is a coronavirus. These are the spikes that you see. But this virus is now called Middle East Respiratory Syndrome Virus, or MERS. You probably heard that term before. MERS, Middle East Respiratory Syndrome Virus. COVID stands for coronavirus. Again, came on the scene in 2012. And then basically all the cases were linked, most of the cases were linked to Saudi Arabia. That's why it's called Middle East virus. So these are the primary countries that were affected, primarily Saudi Arabia, but all these other countries here like Egypt, Qatar, as they call it, Kuwait, Jordan, the Middle East. We saw cases here, but even then, very few cases relative to what we see right now. So again, started back in 2012. The last case we saw was in 2019. Actually, there's probably still some cases going on, but it's not widespread. The total number of confirmed cases is pretty low. I mean, for SARS-1, it was 2002. It was about 8,000 cases. But with MERS, the total number we see that's confirmed so far is about 2,500 cases. So very, very low, but nonetheless still deadly. Take a look at this, about 850. Think about that. That's pretty high. All right, so this was worse than the one that we had with in the 2001 epidemic. In fact, I haven't calculated the death rate here, so 858. Let me just do it, just for my knowledge. I used to know all these numbers, but I'm getting old. 858 divided by 2494. That death rate was 35%. Oh, that's pretty high, 34.4%. That's crazy. That's 1 in 3 people die. So again, good thing this hasn't spread globally, because if it did, we probably have an even worse condition or worse state compared to COVID-19. So this was taken care of pretty effectively. So, yeah, what we see right now, this is our current problem. It's COVID-19 caused by SARS, severe acute respiratory syndrome virus, with this coronavirus 2. All right? And again, if you look at the timeline for this, again, this is an old slide. Everything is being updated. I mean, as the days go by, more people are getting actually testing positive, more people are in the hospital, so the numbers change, all right? But let's go with the timeline for this. This started back in Wuhan, China. We learned about this way back in December 31. This is last year. Some of you were on campus when this whole business started back in January, and then February, nobody was paying too much attention. Then March happened. If you guys remember last semester, then like March 16 or something, the campus closed down. The governor said, you know what, we're going to do a lockdown. Basically, everybody had to go home, and we shut the campus down. That wasn't a nice thing, by the way. We never seen something like that for a couple hundred years. And then it happened in 2020. Think about that. So in December 31, last day of December, basically it's identified. The World Health Organization said, hey, is there something strange going on in China? It's a type of pneumonia that we haven't described before, so it was unknown. Then pretty soon, people recognized it was a coronavirus. We're in January, and then of course everything picked up, right? In March, everything locked down in this country, but worldwide there was a huge problem since when pandemic. Think about what that means. In just a matter of a month or a few weeks, this virus went pandemic. That tells you a whole lot. With globalization, with travel, there's a lot of good things. As I said to you before, lots of great things about traveling to different countries and experiencing culture and all that stuff. But on the negative side, you can transmit diseases from one place to the next. Really, in a matter of days, actually, you travel from China, from the United States to somewhere else, and somebody's infected with a crazy virus like this, you see how the number of cases increase. All right? So anyway, that's other reservoirs. In this case, the most likely animal for transmission is pangolin. Like I said, I never knew what the heck a pangolin was. Now I know. All right. Now the stats. Last week I was looking at this. I always keep stats on these things, and every so often I update this. So this is October 15, 2020. All right, this was last week. Today's the 21st, 6 days ago. So globally, there was about 39,000 cases. 39 million cases. Number of deaths, 1.1 million, and those recovered was about 26 million. So most people recovered. But again, that death rate is still pretty high. That's about 2 to 3 people out of 100 dying because of COVID-19. Now check out the US. This is just the United States now. October 15, the total number of confirmed cases was about 8 million cases. Deaths, about 220,000. Of course, that number increased over this past day. So that was about 2.7. So that kind of consistent with the worldwide stats. Number of people recovered was about 5 million. All right. In California now, this is in our neck of the woods. We have about 867,000 as of October 15th. Of course, that increased. Deaths, 17,000 people. That's 1.9%. And numbers that recovered, we don't have data on that yet. So again, this is an evolving problem. We don't know what the exact numbers are, but nonetheless, you can see it's a very deadly virus. Just for comparison, if you look at influenza, we have way more cases. I mean, on the higher end, 60 million cases just in the United States alone. We're not near there yet. We're just about 9 million people. But imagine if this was something like influenza, where you have so many people infected. And I don't want to scare you. It can be a very nasty outcome. But the cool thing, if anything's cool about it, over time, basically, we adapt to the virus and the virus adapts to us. And it's not going to be as lethal as we think it is, as we see right now. But that's going to take a few years. Hopefully, this stays around just for 1 year, and that's it. We never see it again. And hopefully, it ends tomorrow. I wish if it does, but it's not going to end. We probably have some more problems with this throughout the winter. Hopefully, not in the spring. And hopefully, that occurs just like with MERS and the first one back in 2002. Where it just disappeared for a long time, and we never see it again. All right? Okay, so that's the stats over the this past year. Again, who is at risk? The primary people who are at risk for dying, all right, for getting serious disease and dying are older people, basically people over 65. So again, here's a nice little chart for you to show you the differences. If you're 80 plus, of course, you guys are pretty young, so this is might not be the thing that you're concerned about. But we actually see some problems in people your age now that we really didn't expect. So about 14.8%. All right. So this is the death rate. So it's like 14, 15 out of 100 people who have coronavirus. If you're in that age category, that's pretty bad. That's crazy. That's over 10%. All right. If you're 80 plus, you have 15. This is a 15% chance of dying. That's not nice to think about. It decreases as you get younger, of course, as you in the younger age. And you don't get younger, but in younger age, 79 to 70, it's about 8. This is 8 in 100 people would die. As you get under the 60s, so I'm pretty close to that right now. It's like about 4 people. This is my age group. I'm 58 years old now. So if I were to get coronavirus, I hate thinking about this, but this is just based on stats, reality, right? Basically, I have a 1.3% chance of dying. That's terrible for any disease, by the way. And of course, as you get younger, check this out: 0 to 9 years old, no fatalities recorded. Now, I want to put a little star on this one. It depends. All right. If you have underlying conditions, you might be susceptible to a huge problem. For example, if you have asthma or you have influenza in combination with COVID-19. So all of these stats will change as we enter the winter time. Keep in mind, here's the reason why we're going to be dealing with influenza now. That's already started, right? So this is, if you notice, if you've been outside today, it's getting kind of pretty cold. All right, so now it really feels like fall, especially in the morning. We have this to deal with and then influenza to deal with. That's a terrible combination. All right? Okay, so if we take a look at the progression of the disease, this is what happens. So again, we're looking at COVID-19 caused by severe acute respiratory syndrome, coronavirus 2. It causes COVID-19. So day 1, patients might experience some fever, maybe muscle ache, maybe some pain, dry cough. This persists for about 2 days or so. Maybe they can even have diarrhea and nausea. That's very uncommon, but that's possible depending on the patient. By day 5, this is 4 days later, in older people now, who have pre-existing conditions, now it gets a little more serious. So they have difficulties breathing. And of course, they can be admitted in a couple of days after this. So they have problems breathing, and we all know COVID is going around. They go to the hospital. Day 8, so this is where it becomes more severe. So again, people have underlying conditions, they're older. By day 8, this is just like right after a week or so. Then they develop signs. Check it out. Now, this term is just don't just read the term. It's a very serious consequence. Acute, sudden respiratory distress syndrome. Guess what? This is a bad condition. All right. At this point, if it's so, there's certain levels of basically monitor oxygen levels in the bloodstream, and when it gets to a certain level, guess what? You're placed on a respirator. So this is what we're looking at. All right. So that happens by day 8. By day 10, people can worsen. People can start getting better too. But if you're in that category, it's mentioned for people 80 plus, that definitely like 15%. So again, if you're in that category, just based on stats, it's a pretty bad scenario. So basically, it starts worsening. All right, it becomes worse. People can recover, but if this lingers for a while, death can occur in about 18 days. So this is like about 2.5 weeks or so. So you see what's going on? It's a very miserable virus. Young people typically don't go through this. You might have maybe a mild cold, mild fever, maybe no symptoms at all, but you're infected. Then you can try. Here's what we're worried about, all right? If you have that virus in you, just say, for example, in our classroom, as examples, we have a few people they might not have COVID-19, but guess what? They have been around people who have been confirmed have COVID-19. So they can't be on campus, right? So you guys know all about that. You have to go through student care and all that stuff. Well, that has happened in this class. And again, we do our best to help you out because we want to see you succeed. So in the case where you're exposed, and maybe you don't have COVID-19, but you're exposed to a person, well, you have to be tested. You have to go through a whole protocol before you can come back on campus and be in all classes, labs, for example. But again, we do work with you to make sure you complete the requirements. But that's for young people. It's unlikely that you get a serious disease unless you have some underlying condition like asthma, or you're immunocompromised, or you had say pneumonia before caused by bacteria, and while you're recovering from that pneumonia, now you get COVID-19. So there are all of these combinations of things that can occur that can give you a very bad scenario or bad outcome. But nonetheless, older people over age 80, it's a very serious complication, very serious condition that can occur. So death typically occurs in these individuals after 2 weeks. Okay, and again, we can go through this here. So this is the types of symptoms that people have. And again, you can almost guess it's a respiratory syndrome disease. So you can have problems with breathing. Fever, of course, the virus induces fever. Fatigue, sore throat, these are all general types of symptoms. And when it gets pretty severe, you have pneumonia now. You have severe acute respiratory syndrome that can lead to death. Right? So far, there's not effective vaccines. There's no vaccines that we know of. We know a lot of companies actually put this on fast track to develop a vaccine in this very short period of time. That's like a miracle. But apparently, there are a few good candidates out there. We don't know much about them. Again, this is all evolving as we speak. Hopefully, by the end of the year, we actually do have a vaccine. Now, think about this. I say, hopefully we have an effective vaccine. It takes years before people can prove the efficacy. In other words, does it do what it's supposed to do? Of vaccines or any drugs per se. So whether this works effectively, who knows? Or whether it becomes like, think about influenza. Every year you have to make a new vaccine. I hope it's not the case. I can imagine having this every year. So there's a vaccine for influenza. Now there's a vaccine for COVID-19 or the SARS-2 coronavirus. So this is, we just don't know yet. But anyway, some people are predicting that we have vaccines on the market to be given to people, especially those who are more susceptible, by the end of November, but it's close there already. We haven't heard much about that. But most people are thinking it's likely in the spring. So again, I think we have to go through these winter months, just handling this nasty disease. All right? So again, this is more molecular biology. I've told you the basic things I want you to know. I told you the receptor. I like it. That receptor is called the ACE2 receptor. Very important. And the last thing I want to say, all right, regarding a couple of things actually. When the virus binds to the receptor, it can induce many different things in the body. So people who are most susceptible, they experience something called a cytokine storm. All I want to say, just put this in a nutshell, it causes major inflammation. So that's a huge problem. When people die, basically they have lots of edema, fluid building up in other areas. And again, you have to remember, I don't care that you memorize all this stuff, but that virus can lead to what we call a cytokine storm. These are chemicals that activate other white blood cells, but nonetheless, this is what happens. Major inflammation that can occur. And of course, your blood volume goes down, and you can end in what we call hypovolemic shock, and then people can die because of this. Again, in your age group, it's not much of a problem. Younger people, not much of a problem. Why? Because you don't have too many receptors compared to older people. So the older you get, apparently, the older you get, the more ACE2 receptor you have. All right? So again, this is just enough for you to memorize, so you don't have to know all of this stuff. But take a look, what does this cytokine storm that I just mentioned does? What effect does it have on the body? What are the clinical features? Fever, all right? In other words, you can't make blood cells effectively. Intravascular coagulation, if you take in Bio 162, we talk about something called DIC. You have other things, liver damage, anemia, respiratory collapse, of course, cardiovascular collapse, and then, of course, the worst thing can happen where people die. All right? So, again, this is not for you, but it's just to tell you this is a very nasty virus. All right? So all of this stuff, when it comes, look at me for a second, when it comes to mechanisms, all these, don't memorize this stuff. Things I pointed out, the virus binds to ACE2, and many people, especially people who are susceptible, older people, we have a cytokine storm. Chemicals that are produced because of that interaction causes many different problems that can lead to death. All right? Now in kids, although kids are less susceptible to this, there's a condition that seems to occur in kids with certain predispositions, or they have previous existing conditions. That condition is called multi-system inflammatory syndrome. It's relatively new. Nobody really understands what it is. I probably wouldn't test you on something like this because we're not even sure what this disease is. But in kids who have some underlying conditions, all right, and now they get COVID-19, they get that virus that causes COVID-19. They have what we call multi-system. Look at the cardiovascular system, the kidneys, whatever it is, all right, inflammatory syndrome. So this can be quite quite dangerous in these individuals. A few kids have died from this, but the numbers are very, very small. So I don't want to tell you something and say, this is happening because of COVID-19. I really can't say that because we're just learning about it. But just to be on alert, and a few individuals who may have underlying conditions, kids in particular, we don't expect to have a major problem. They can have some major serious consequences. All right, and that's listed here, meningitis included, cardiomyopathy, basically cardiovascular problems, kidney problems, and so on and so forth. All right. Okay. As far as treatment, I do want you to know this. All right. So we don't have a vaccine yet. It's likely that we would have one soon, but that's up in the air. This is all new stuff. But you probably have been hearing about some antiviral drugs that's used all the time. So remdesivir, I do want you to know that word. This is an antiviral. Kaletra, it's another, so you know these terms here. Kaletra, remdesivir, these are antivirals. Here's what they do. They kind of slow down the viral replication. And apparently it's quite effective, actually. So remdesivir in particular, again, you probably hear about that in the news. Or Kaletra, these are examples of antivirals that kind of limit or slow down virus replication. So this is for viral replication. Of course, because there's so much inflammation, one of the things that we use is dexamethasone. All right, so dexamethasone. So this is to reduce inflammation. It doesn't affect virus replication, but it reduces inflammation. So you use these in combination. And there are other things you can, like prednisone, to reduce inflammation. Immunotherapy, yeah, hopefully there's a vaccine, but you can use convalescent plasma. In other words, there's somebody who had COVID, right? They had COVID-19, and of course they became immune to it. They don't have the disease anymore, or they have antibodies floating around their plasma. You can collect that plasma and then give it to someone who has a very serious case of COVID-19. And it has shown some promise. Again, this is all new stuff. Whether or not it works long term, we do not know. All right. So as I hate to say we don't know, but think about this. This pandemic just came on the scene this year, so we're still learning a lot about this problem. All right. COVID testing. So COVID-19 testing. Basically, you can take a nasal swab. And this is a nice procedure because they go all the way up, and if you had one done, you can also do a blood test, and you look for antibodies to. Different things we can use. We can use a specimen, a nasal specimen or nasal swab, and you can actually detect the nucleic acid. In other words, the genome of the virus in that specimen. Or you can do a blood test where you're looking for antibodies. So these antibodies are produced in response to the virus. All right? Don't worry about this. Don't memorize all these different types of inhibitors. That's not simple. Right? That's not. This is, by the way, this is like a concept map after we talked about some very general things. You should be able to go back to this little concept map and say, I think I understand, at least at the basic level, coronavirus 19. Right? Okay. Wow, there's a duplication of slides back here. Ooh. All right. Okay. So at the end, I have some viruses I'd like to talk about. For example, hantavirus, but that's miscellaneous. All right, so I did promise to end here. These are duplicated slides. I'm not sure why they're there. So this slide should be here. You saw that before. All right. You saw this one before. For some reason they got juxtaposed. You saw this one before. The next section actually starts with dermatophic viruses. So these are virus infections of the skin. I'm not going to start that today. I'm going to start this on Monday. All right. Okay, so I don't want to rush too much information on you. We have enough time. We can slow down a little bit. So on Monday, I'll come on and complete dermatophic viruses, and then on Wednesday, I'll complete oral virology. So we'll be done with viruses next week.